Good morning, Mr. Isle.
Morning, Madam Chair.
Ready to proceed?
We are. The first witness this morning will be Professor Sutton, but prior to having him be sworn in or take the affirmation, I'll tender a statement of a witness who won't be called. That's the statement of Jacinda DeWitt, a Deputy Secretary of the Department of Health and Human Services, formerly the Deputy Secretary of the Covid-19 response. Her statement is document DHS.999.001X.0001_R. So I tender that document.
Exhibit 151.
And Madam Chair, as with the other statements, there's a number of documents referred to in that statement, and I tender them as a bundle.
That bundle will be marked Exhibit 152.
The board pleases. There are no other matters prior to commencing with the witness, so I call Professor Brett Sutton.
Good morning, Professor Sutton. I'm sure you've had explained to you that for the purposes of giving your evidence, you need to take a solemn promise, and I understand you wish to take the affirmation.
That's correct.
So I'll ask my associate to take you through that. Thanks, Madam Associate.
Please repeat after me. I solemnly and sincerely declare and affirm that the evidence I shall give will be the truth, the whole truth, and nothing but the truth.
Thanks, Professor Sutton. I'll hand you over to Mr. Isle now. Thanks, Mr. Isle.
Thanks, Madam Chair. Good morning, Professor.
Good morning, Mr. Isle.
Can we start with your full name, please?
Brett Andrew Sutton.
And you are a Professor of Medicine?
I'm a Professor at Monash University in the Department of Public Health. And yes, I'm a public health physician.
Thank you. You're also Victoria's Chief Health Officer?
That's correct.
And that's a position you have held since March of last year?
Yes, substantively.
And you also hold the position of Victoria's Chief Human Biosecurity Officer?
That's right.
Yes, thank you. You've provided a statement to this inquiry in response to a number of questions that were posed to you?
Correct.
That's a statement dated the 13th of August of this year?
I believe so.
It comprises some 48 pages and then there's an attachment as well, but the substantive statement itself is 48 pages long?
That's correct.
Are the contents of that statement both truthful and accurate?
Yes.
Yes. I tender the statement of Professor Sutton dated the 13th of August, Madam Chair.
Exhibit 153.
The board pleases. I referred to just a moment ago an attachment to that statement, Professor. That's a list of directions made from the 16th of March through till the 3rd of August.
Correct.
And are the contents of that list both truthful and accurate?
To the best of my knowledge, yes.
Yes, thank you. I tender the attachment to the statement of Professor Sutton being the list of directions from 16 March to 3 August inclusive, Madam Chair.
Exhibit 154.
As the board pleases. And Professor, finally, in relation to the documents and tender, there are a number of other documents referred to in the body of your statement. Is that right?
That's correct.
And they're documents that you've had reference to in the preparation of your statement and documents that you seek the board have before it to read the answers you've provided in full context.
That's correct.
Yes. I tender as a bundle, Madam Chair, those documents referred to in the statement of Professor Sutton.
Exhibit 155.
What pleases. Professor, can I just ask you to briefly outline your role as Chief Health Officer of Victoria? What does it involve?
Essentially, it's an expert advisory position to government on matters of health protection or public health, classically issues of food safety, environmental health and safety, and communicable disease control and prevention. It's also a statutory position that holds powers delegated to me by the Secretary of the Department of Health and Human Services under the Public Health and Wellbeing Act that are broadly for the protection of the health and wellbeing of the Victorian population. And I'm also represented nationally in the Australian Health Protection Principal Committee with all other Chief Health Officers, Chief Preventive Health Officers or Directors of Public Health in that committee chaired by the Chief Medical Officer. And I'm represented in other national bodies such as the NHMRC Council, and I provide policy and strategic advice on matters of public health more generally, and I am a spokesperson on matters of public health when appropriate for the department.
Yes, thank you. And can I just ask you then, in a business as usual model, if there's such a thing for a Chief Health Officer, let's say when we're not in a pandemic or a state of disaster or state of emergency, can you explain your reporting lines? Who reports to you and who do you report to?
Certainly prior to the Covid-19 pandemic, I was reported to by two Deputy Chief Health Officers. Deputy Chief Health Officer for Communicable Diseases with a portfolio across a number of areas relevant to communicable disease, including the immunisation team, communicable disease prevention and control, communicable disease epidemiology and surveillance, the partner notification and support unit with regard to matters of sexually transmitted infections, and a public health medical unit consisting of senior medical advisors, often public health physicians, also a Deputy Chief Health Officer Environment, who covered a portfolio of broad environmental health risks and regulation and compliance matters, but was as diverse as Legionnaire's disease in cooling towers, radiation management, pest control, environmental health, risk management and food safety in the broader sense of managing the risk of foodborne outbreaks in particular, but also support to local government in their enforcement of matters related to food safety. There was also a position of business support unit that gave broad support to the branch in support of all of my functions.
And in that business as usual model, if we can call it that, to whom do you report?
To the Deputy Secretary of Regulation, Health Protection and Emergency Management.
And that position is currently held by Ms. Skilbeck, is that right?
That's correct.
Yes. And then when we move into the COVID-19 specific era, did your line of report, that is who you report to, change at some time?
It did. We stood up a command and control structure, an incident management team, and so my direct reports changed in the sense that I was supervisor for the public health commander and whomever was in that role through that period. I remained reporting to Melissa Skilbeck, but at some point Jacinda DeWitt provided support to that response, and then I formally reported to her as a Deputy Secretary role across that COVID division.
During that period, did you have two lines of report, one to Ms. Skilbeck, one to Ms. DeWitt, or did it all consolidate into Ms. DeWitt?
No, it remained a dual reporting line.
And why was that?
Essentially because the business as usual functions continued, and my statutory obligations to protect the health and wellbeing of Victorians across that broader portfolio continued. And even though there was a pretty substantial delegation to the Deputy Chief Health Officer Environment and an acting Deputy Chief Health Officer for communicable disease, so that I didn't have to spend enormous amounts of my day on the details of all of those other business as usual incidents and activities, I was still accountable in that sense, and I did need to maintain that line of accountability to the Deputy Secretary of that division.
Yes. So if we look at the structure of the portfolio of health, if we can call it that, we have the Minister of Health, we have the Secretary
Correct.
of the Department of Health and Human Services. Below the Deputy
Yes.
Secretary, below the Secretary, have a number of Deputy Secretaries, and you've identified two of those positions that you report to through the COVID-19 response.
That's correct.
Are you aware of the structure in other states of other relevant Chief Health Officers and who they directly report to?
Not in full, but I understand that Queensland and New South Wales have Chief Health Officers who are more akin to a Deputy Secretary level and report to a Secretary, I believe.
Yes. In Ms. DeWitt's statement, a document which has just been tendered as an exhibit in this proceeding, Ms. DeWitt describes her role as the Deputy Secretary of COVID-19 Public Health Division as providing yourself and the Public Health Command operationally with executive functions. That's at paragraph 9. Can you describe, at least from your perspective, what that means?
Effectively, it was representing our work and ensuring that the issues that arose that required executive awareness and action at the executive board level of DHHS or reporting through to the Secretary were facilitated by Ms. DeWitt and providing the overarching coordination of the activities of a very large workforce that had been in a command and control structure, but that was growing, that was complex, and that was likely to require a sustained response over several months and potentially, well into 2021. And so it was to try and bring a more sustained, almost bureaucratic structure to that command and control structure that had brought in people from various other divisions of the department, but also staff from Safer Care Victoria, a number of seconded individuals from other academic institutions and other agencies. And so it was to really give the oversight to some of the bureaucratic requirements administratively and organisationally to that rather large beast. Yes.
Ms. DeWitt also identifies in her statement that you and your team, first of all, is it correct to call the Public Health Command part of your team?
Public Health Incident Management Team or Public Health Command, yes, that's fair.
Yes. So one of the functions of you and your team, indeed the primary function of you and your team, was to provide advice to the government. Is that fair?
Yes, it is.
And Ms. DeWitt says that notwithstanding your reporting to her in respect of that advice, specifically on COVID-19, that she didn't really have a role in approving that advice.
That's a fair statement.
Yes. So is she merely a conduit through whom that advice travels up to the executive level?
Not merely a conduit, but yes, she was a point of liaison for that advice into the department, although there were other direct mechanisms for that advice to occur for me to raise issues with the Minister directly. We had a number of other meetings where Ms. DeWitt was not present and not required to be present for that policy or strategic advice to be provided to the Secretary or to the Minister's office.
Now, the types of advice that we're discussing covered a range of topics, did it not?
It did.
It included infection prevention control advice.
Not so much advice to the Minister or advice to the Secretary on those matters. They were operationally managed within the Public Health Incident Management team, but they were broad areas of responsibility.
Mm. Did the advice that came out of the Public Health Command or the Public Health Incident Management team include from time to time advice on the use of personal protective equipment?
Again, yes, they were matters that the Public Health Incident Management team landed and developed policy guidance on for various purposes in non-healthcare settings and healthcare settings.
Mm. And cleaning in both of those settings as well?
Yes, they would have.
And you say, Professor, at paragraph 143, first of all, that notwithstanding you've provided this advice, that, and this is a quote from 143, my team and I did not have oversight in relation to IPC personnel and process in place at each hotel. I just want to unpack that for a moment in the context of the advice and policies we've just been talking about. Are you saying there that although the Public Health Command prepares these advices and policies, they're then deployed into the system at large, and we're going to come specifically to the system in respect of hotel quarantine, but your team doesn't have oversight into how those policies are being proliferated and whether and how they're being complied with?
Yeah, I think that's a fair statement. We were providing advice through the infection prevention and control cell within the Public Health Incident Management team to innumerable settings across the state, from public transport settings to residential settings to various other settings. And so oversighting how that guidance or policy direction was implemented across the state in all of those settings was not part of our purview.
Mm. Coming specifically now to hotel quarantine, we know and have been taken to a number of policies that came out of your team about the use of PPE. I think you referred to use of PPE in non-healthcare settings, cleaning, those types of matters. And acknowledging that your team didn't have oversight in it, it's the case, isn't it, as you've stated at paragraph 144, that until the outbreaks, and specifically Ridges and Stamford, you were not aware of the sufficiency of the infection control processes in place? That's
correct.
So these policies are drafted by your team. They're then sent to whoever needs to proliferate them down to the people on the ground, and your team's not aware, at least until the outbreaks, as to the level of compliance or otherwise.
That's correct.
I want to turn briefly, if I may, Professor, to your role as the Human Biosecurity Officer of Victoria. That's a role that you hold in addition to your role as the Chief Health Officer.
That's correct.
That's a role, Human Biosecurity Officer, which exists not under Victorian legislation, but under Commonwealth legislation.
That's correct.
In your experience, is it usual that the Chief Health Officer or Chief Medical Officer of a state or territory hold that dual commission, once as Chief Health Officer and also as the Human Biosecurity Officer?
It's neither uncommon nor common. About half of the Chief Health Officers, I think, across Australia might hold that role as well, but it's often held by the lead for communicable disease within those jurisdictions. So a level down, if you like. So the Director of Communicable Disease Control within a jurisdiction or a Deputy Chief Health Officer position for communicable diseases would not infrequently hold that position instead of the Chief Health Officer.
Mm. And the legislation which governs the function and power of the Human Biosecurity Officer of a particular state is the Commonwealth Biosecurity Act 2015.
That's correct.
And broadly speaking, this is not a law exam, but broadly speaking, you're familiar with the powers that exist under that act.
I am.
But you would agree then, wouldn't you, Professor, that under Section 60 of that Act, officials can make a number of orders pursuant to the powers vested by that Act?
Yes.
And they are orders or powers that can be exercised in respect of individuals who are suspected of having symptoms of a listed human disease.
Yes.
Or in relation to individuals who are suspected of being exposed to persons who have those symptoms.
Correct.
Listed human disease is a term of art under that Act. Are you able to assist us as to whether COVID-19 is a listed human disease?
It is a listed human disease. There's a listed human disease designation of coronavirus with human pandemic potential. And so it would fall under that specific designation if it's not otherwise specifically listed.
And that general designation of coronavirus with human coronavirus with pandemic potential was a listed human disease long before we actually saw this virus, wasn't it?
It was. On the basis of the experience of SARS, even the experience of MERS, that human-to-human transmission with these coronaviruses occur, that disease is very severe, and that therefore, even if a pandemic hasn't occurred, that the potential is there.
And the powers that vest, firstly, within you as the Human Biosecurity Officer, but indeed others, we have Chief Human Biosecurity Officers, Human Biosecurity Officers, and biosecurity officers, a cascading sort of sequence of positions.
Yes, although it's fair to say that the Chief Human Biosecurity Officer in any jurisdiction doesn't have different powers to human biosecurity officers in general. There's a title that is held so that there's a go-to person, if you like, as the Chief Human Biosecurity Officer, and therefore coming together with other CHBOs in national fora to discuss human biosecurity matters. But in terms of the exercise of those powers under the Biosecurity Act, it's the same for all human biosecurity officers.
Yes, thank you. And those powers include, well, first of all, those powers exist irrespective of whether a state of emergency or state of disaster has been declared, don't they?
They do.
And those powers include requiring an individual to provide contact information.
Yes.
Requiring an individual to provide health details.
Correct.
Restricting the behaviour of an individual.
Potentially, yes.
Requiring individuals to undergo risk minimisation interventions, including decontamination and or medical treatment.
Yes.
Or requiring individuals to accept isolation from the community for specified periods.
Correct.
In your role as Human Biosecurity Officer for the state of Victoria, did you ever consider utilising any of these powers, that is under the Commonwealth legislation, in respect to the COVID-19 response?
Certainly I had consideration of what role the Biosecurity Act might play with respect to individuals travelling internationally and arriving in Victoria. I think one of the issues with the Biosecurity Act is that it has always been applied with respect to individuals arriving and with regard to the assessment of those individuals and their risk to the community. And the orders and the powers that apply in those orders that you've elucidated are really for the purpose of managing that individual who might be a risk by virtue of having the listed human disease or being suspected of having that listed human disease. and is not historically, and as far as I know, in any other jurisdiction in Australia, applied to a class of persons more broadly for the purpose of the Biosecurity Act.
If I can understand that answer, and excuse me if I'm oversimplifying it, but is that a way of saying that the Biosecurity Act or the powers under the Biosecurity Act are not particularly well tailored for a situation where you're dealing with a lot of people and need to make orders in respect of a lot of people?
Yeah, I think that's fair to say, and certainly my understanding, the intention of the Biosecurity Act is to manage the risk of importation of serious diseases, listed human diseases, at ports of entry in Australia, with the human biosecurity officers having a role on behalf of the Commonwealth to manage them at that point of entry, and that the exercise of those powers would effectively be meeting them at that point of entry and then managing that risk there, including referral to hospital or referral to an isolation ward until such risk has passed, and not the management of those individuals when they have already entered a jurisdiction and are within the community more broadly. It's not out of the question, as far as I understand it, but it's never been spoken of as a routine application of those powers amongst Chief Human Biosecurity Officers.
I asked you the question first of all in the general sense, whether you considered using those powers during the COVID-19 response, specifically when the issue of the hotel quarantine program arose, and that was directed to people that were re-entering the country from overseas. Did that enliven some consideration of the Biosecurity Act powers?
It did, but again, to the extent that the more usual application of powers would be under Victoria's own public health and wellbeing powers, which had been drafted with consideration of managing pandemics and this particular risk. I think the legal view presented to me was that it was the application of the Public Health and Wellbeing Act powers that were more appropriate in this setting.
Just so that I can understand that, we have two suites of powers, both that vest largely in you. One, as the Human Biosecurity Officer under the Commonwealth legislation. Those powers include the ability to direct people into isolation for specified periods. On the other hand, powers that vest in you as the Chief Health Officer, and we'll come to those specifically in a moment, but in the context of a state of emergency being declared, that includes authorised officers to exercise those public health risk powers in Section 200.
That's correct.
And is your evidence to the board that that latter category, that is the powers under the Public Health and Wellbeing Act, are better suited to the situation that was faced in respect of COVID-19 and specifically the hotel quarantine program?
Yeah, again, not being a lawyer, it's my view that the Public Health and Wellbeing Act specifically had in mind the scenarios of pandemics. It was drafted with knowledge that Australia had gone through pandemics in the last century where such powers might need to be utilised, and had a design that enabled the exercise of some of those necessary or potentially necessary powers to manage pandemic risk.
Thank you. Let's move to those powers in more specific detail. Under the Public Health and Wellbeing Act, there's a range of powers. First of all, there's those ones we've touched on. They're the Section 200 powers that vest in the authorised officers pursuant to an authorisation conferred by yourself as Chief Health Officer.
Yes.
You describe those powers in paragraph 12D of your statement as coercive emergency powers.
Correct.
can you explain, perhaps it's self-evident, but can you explain what you mean by coercive in that context?
In the sense that those powers enable an authorised officer, orally or in writing, to exercise the powers under the state of emergency that can include detaining persons for a reasonable period of time in order to manage the risk specifically of transmission of coronavirus in this pandemic, or restricting the movement of people within an area. That's less relevant in this setting, but it does refer to circumstances where you might have a what's called a cordon sanitaire that applies to a well-defined geographical area where you don't want the movement of people in or out because the transmission of illness is thought to be entirely within that area. But the detaining of people are essentially the reference to those coercive powers.
I just want to seize upon the adjective coercive in that context. Coercive means, and you intend it to mean, the ability to do something in respect of a person irrespective of or even against their will.
That's correct.
You can force someone to do something even if they don't want to do it.
That's correct.
Yeah. You also identify in paragraph 12B a number of coercive powers. Again, you've used the adjective coercive, that vest in your office as Chief Health Officer under the Public Health and Wellbeing Act.
That's right.
And the powers that you referred to at 12B as opposed to those at 12D, they're powers that subsist in your office irrespective of a state of emergency having been declared, aren't they?
That's right.
So they're powers that you as the Chief Health Officer hold as long as you hold the office as Chief Health Officer.
That's right.
And that includes the power at section 113 of the Public Health and Wellbeing Act to order coercive examination or testing of a person.
That's right.
And in section 117, we see powers that are broadly reflective of those under the Biosecurity Act. That includes, for example, refraining people from certain behaviours.
Yes.
Orders that restrict or prohibit people from engaging in particular activities.
Correct.
Powers requiring people to reside at a particular premises.
Correct.
To submit to supervision.
Yes.
And to submit to isolation from the community or even detention.
Correct.
It also includes a power, that is these coercive powers that exist notwithstanding there being no state of emergency, the power to direct a person to provide truthful information.
Correct.
Now, those powers that we've just gone through, 113, 117, 188, did you consider using any of those powers in respect of the COVID-19 response?
I didn't. They have, again, routinely, not routinely, but they have historically been used from time to time for individual persons for those issues. They relate to infectious diseases and some other settings, such as with respect to food safety, where directing individuals or directing premises is warranted on an individual basis. Testing orders, for example, might be applied if a healthcare worker has been exposed to a needle stick injury and you want to know the status with respect to infectious diseases, hepatitis B or C or HIV, of the person whose blood was in the syringe that was involved in that needle stick injury. And if that information is not forthcoming, and if you think it's appropriate and proportionate to make sure that that person is tested to find out, then those orders can be applied in that instance. So that's an example. There are some examples, again, where someone with an infectious disease is putting others at risk by virtue of their behaviours, sexual behaviours or other behaviours, where the risk to other people is so grave that you either provide a letter of warning or that you give direction to constrain their activities. And again, those have been applied infrequently, but historically for individual persons.
You say that those powers have routinely or historically been used in those types of cases. You are aware of any reason as to why they could not have been used in response to, say, for example, contact tracing efforts?
Again, not being a lawyer, I don't know exactly why those powers, which are clearly the powers that are being used with respect to contact tracing. Well, they're not enforced in contact tracing. Contact tracing is overwhelmingly done through a voluntary and cooperative engagement with cases and close contacts. But they are available, and if they were felt to be required, I wouldn't discount them from being used, including for ensuring the provision of appropriate information or to direct people to behave appropriately. But for a class of persons across an entire state, the use of those individual public health orders is impractical.
So you say that they are available, but is it the case that you haven't considered using them?
The issues where they might be required haven't been raised with me. So I take that to mean that there haven't been circumstances where a recommendation from the case contact and outbreak management team haven't seen circumstances where they feel that such coercive powers would be beneficial to the work that they're doing. I think there is always a consideration about how the exercise of such powers might affect ongoing engagement with the critical function of case and contact management, the trust and rapport that is fundamental to being able to engage with people and have the honest provision of information, and also the willingness of people to come forward for testing with an understanding that if they test positive, they will need to go through a process of defining their close contacts, constraining where they move to, and constraining their behaviours. And so there is always a trade-off. If there is an individual who might not be providing that information or who might not be compliant with advice, what the consequences might be for the broader community going forward.
What about those powers in respect of testing? We've heard that in the hotel quarantine program, testing was entirely voluntary for those that were in the system. First of all, the evidence reflects that testing was only available for those that were showing symptoms, but then later became more available. Firstly, is that your understanding of the evolution of testing in the hotel quarantine program? It was only available for those with symptoms, but then later became much more readily available for everyone?
Yes, essentially that's the case. In the beginning of the hotel quarantine program across Australia, there was certainly a view that anyone who became symptomatic needed to be tested because they were developing the signs and symptoms of coronavirus, and they needed to either be excluded from having that illness or to be confirmed as positive and therefore managed in isolation. And later, and you have to bear in mind that the purpose of quarantine is to have someone isolated for a 14-day period, because the 14-day period is the maximum incubation period for coronavirus. So that from the time of being exposed to the time of developing illness is 14 days. And if you haven't developed illness in that 14-day period, then you haven't become infected, and therefore you don't need to remain in isolation beyond that period. What became known over time is that some people can have extremely mild symptoms. Some people might develop asymptomatic illness, so with no symptoms whatsoever, but potentially be infectious. And some people, I think we were reflecting on the fact that some people might want to minimise their symptoms whilst in quarantine in order to not be detained for longer than that 14-day period. Because if they develop symptoms on day 11, day 12, day 13, and they wanted to get out of quarantine, then they might not declare it, and it might not be easy to identify those individuals as unwell, especially if they had very mildly symptomatic illness. And so the testing at day 3 and day 11 was something that Victoria instituted. I think we were the first to do it routinely in Australia, in part to pick up those with very mild illness who may not even be aware that they were becoming unwell, but also as an additional stopgap measure to identify illness in people who might be minimising their own symptoms.
Professor, I just want to take up something that you just said in answer to that question. So I understand it. You said that there may be people who downplay their symptoms because they fear that they will remain in quarantine for a longer than otherwise period. It was never the case, was it, that people who were symptomatic were held beyond the 14 days?
Not in hotel quarantine, but they would have had a requirement for isolation for the entire duration of their illness.
At home?
At home. Yep. Or indeed, if they felt that they couldn't isolate at home, then we would support them with alternative accommodation arrangements. Yes.
So just coming back to where I started, was there ever any thought about using the powers that vested in you, either under the Biosecurity Act Commonwealth or the Public Health and Wellbeing Act, to enforce testing?
No, there wasn't. Again, it was a stopgap measure for those in quarantine. Essentially, it became increasingly apparent that if you want to make hotel quarantine as robust as possible and have not 1 in 100 or even 1 in 1,000 leave quarantine potentially infectious and not being aware of it, that making more stringent requirements for testing is a reasonable consideration. It didn't come to mandatory testing, but there was a change in the directions, in the public health directions, which specified that those who were refusing testing at the day 11 or thereabouts mark would be held for an additional 10 days if they didn't get tested, and those additional 10 days are really a conservative measure of the infectious period if someone were to become unwell on the very last day of quarantine. Most people who develop illness have recovered and are no longer infectious before 7 days are up, and certainly the great majority will be non-infectious at the 10-day mark. So that mechanism was used instead.
That mechanism, though, and you talked about majorities and vast majorities, always recognised the possibility, did it not, that people would be released from quarantine carrying the virus and still infectious?
That's right. As for others in the community, as for others in the community who are identified as cases who were also isolating at home. Were the substance of the outbreak management reports brought to your attention? I was in copy on a group email with the summary of the outbreaks that were added every day, and those that were still active. They numbered dozens at different points in time.
It came to your attention, didn't it, that there was a person at the Stamford Hotel who completed their hotel quarantine and then subsequently tested positive for COVID?
That's correct.
And that subsequent test revealed on a genomic tracing basis a connection between the virus that that person had and the source of the virus at the Stanford Hotel.
That's correct.
You're also aware that that person who left hotel quarantine unaware that they were COVID positive actually transmitted COVID to the person who drove them away from hotel quarantine.
That's correct.
That perhaps demonstrates, does it not, Professor, the risk of a 14-day period where people will be released from quarantine without knowing definitively whether they're COVID positive or not?
Yeah, I think that has become part of the reflections on strengthening the testing regimen within hotel quarantine for that very purpose.
And it's the case, isn't it, that there were others who would have been released from hotel quarantine where their status as to whether they were COVID positive or not was not known?
Yeah, that is potentially the case. Again, they would have been questioned as to whether they had any symptoms, and would have been released on the basis that they were declaring that they were symptom-free.
And even those that were declaring that they did have symptoms, they were then falling to be treated just like every other member of the community.
Who had coronavirus, correct?
Well, first of all, if they only had symptoms but no confirmed test, they were not falling subject to isolation at home, were they?
No, but people who had symptoms were being tested. There were individuals who were symptom-free who were not being tested, who were finishing their quarantine period, again, symptom-free, who were being released.
So sorry, I just want to understand that a bit better. Are you saying that everyone who had symptoms was tested?
That was my understanding. It wasn't brought to my attention that there were individuals who were symptomatic leaving hotel quarantine without a test.
There was no power, though, was there, to keep them in hotel quarantine if they were merely demonstrating some symptoms but refusing a test?
No, other than the issue being escalated to me and for consideration of an individual public health order for the purpose of testing or the purpose of isolation, for example.
But that didn't happen?
That did not happen.
Okay. I want to ask you a couple of questions about what you've addressed in your statement at paragraphs about 58 and following about pandemic planning. And as I understand your evidence today, you say that the Public Health and Wellbeing Act has been drafted, at least in part, to deal with the situations that might arise from time to time when we have pandemics.
That's correct.
You've talked about in paragraph 58 of being aware of an exercise in August of 2018 called the Alchemy exercise. First of all, I understand that you weren't involved in that exercise.
That's correct. I was invited to be involved as Deputy Chief Health Officer for Communicable Diseases at that time, but I wasn't able to make it.
What do you know about that exercise and what did it involve?
Again, not having been directly involved, my understanding was that it was a biosecurity issue in animals. I think it was an avian influenza scenario with transmission to humans, and then with concerns about disease transmission with pandemic potential.
The next exercise I want to ask you about is something called Exercise Teapot, which was undertaken on the 10th of September last year. First of all, was that an exercise that you were involved in?
I was.
Can you explain what that exercise was about and what came out of it?
It was an exercise that had a scenario of essentially a mass water contamination and mass presentation of illness at a gathering. And it was essentially akin to the outbreak of E. coli that occurred across Europe that you might be aware of, where fenugreek seeds were implicated, and there were many deaths across Europe, and thousands of people who became unwell. So a similar E. coli contamination event, where the issue was the coordination of local government, water authorities, the water unit within the health protection branch that have carriage of oversight of water safety with respect to drinking water under the Water Act, Clean Water Act, and the coordination of emergency management and public health responses to that mass event.
You say in your statement that, and perhaps I'm misreading it, Professor, and tell me if I am, that Exercise Teapot was a discussion exercise attended by representatives of the department and multiple agencies, which explored a complex multi-agency emergency involving widespread outbreaks, including of MERS. Can you talk us through how MERS came into what might have been a discussion about E. coli and fenugreek?
Sure. Look, I might be overstating the role that MERS played in that scenario. It was an add-on on the end. So it was primarily a waterborne disease outbreak scenario. But then there were some individuals at that mass gathering who presented with respiratory illness who were confirmed as having MERS coronavirus. And so it was, and how do we manage these parallel contemporary challenges across agencies? But it wasn't looked at in depth. It was very much and here's the additional challenge for all of us.
Professor, have you had an opportunity, or did you watch the evidence of Professor Grayson on the first day of evidence in these hearings?
I'm afraid I haven't.
Professor Grayson touched upon, in answer to some questions from senior counsel assisting, the lessons that could be learned or have been learned in relation to previous pandemics. And he cited SARS, he cited swine flu, and he cited MERS as three relatively recent and prominent examples of pandemic situations.
Or potential pandemic situations.
Yes. Well, first of all, the virus H1N1, or the virus known as H1N1, tell us a little bit about that. When did that become a problem globally, and how was it managed?
So with respect to swine flu, H1N1 was the new virus that emerged with swine flu. There are other H1N1s that have been circulating over time, but I'm sure your reference is to the pandemic H1N1. And so it emerged and had pandemic potential and swept around the world in 2009. It was, as pandemics go, relatively mild compared to, certainly compared to 1918, 1957, 1968. It was probably the mildest of all of those four pandemics. That said, pandemics affect a significant proportion of the world's population. They go to every country in the world, almost. Certainly influenza pandemics are known to travel to almost every corner of the world. And even mild as a pandemic is usually on the very severe end of what a seasonal flu season looks like. And so it was challenging regardless. As a mild pandemic, it didn't stretch health services in the way that previous pandemics might have, but it was certainly a significant challenge with respect to trying to minimise the illness and deaths that occurred from that. The other features of influenza pandemics is that they don't affect the vulnerable cohorts classically identified in seasonal flu. Those are individuals who are very elderly, those with significant pre-existing chronic illness, even though they are also vulnerable to pandemic flu. Pandemic flu can often affect other younger and fitter cohorts of the population. And so pregnant women, for example, were at much more significant risk of illness and death from H1N1. And there were other younger cohorts of individuals who were also challenged with that flu.
You're aware, aren't you? Well, first of all, in your role as Chief Health Officer, part of your responsibility is to be forward-thinking about how we deal with pandemics that might be coming down the line, new infectious agents, things like that.
That's correct.
Yeah, and your engagement on national committees is at least in part directed to those types of issues as well.
Yes, we certainly, well, it was more as Deputy Chief Health Officer, Communicable Disease, and CDNA, the Communicable Disease Network Australia, which I was the Victorian representative on in that role, that talked through the Australian Health Management Plan for Pandemic Influenza, its revisions, and the Victorian Health Management Plan for Pandemic Influenza as a reflected piece with a Victorian focus.
Professor, are you aware, given those significant roles you previously had, and of course the significant role that you currently hold, of an Australian Government Department of Health and Ageing review of the Australian health sector's response into the H1N1 pandemic?
Yes.
Yeah. I might ask that document be brought up, Madam Chair. It's HQI.001.003.001. Now, Professor, you understand this document to be the result of a review that was done by the Department of Health, that is the Commonwealth Department of Health, but with input from state agencies about how it was that Australia handled H1N1 and the lessons that might be learned from it going forward.
Yep.
Is that right? Yep. Can we go to page with Roman numeral 5, please? It's the page headed Executive Summary. And if we can highlight the first text box in the top left column, please. This is a document with which you're generally familiar, Professor?
Yes, it's been some years since I've looked at it, but I would have seen it.
Yes. You'll see that it starts clearly. There are many lessons for health officials and governments to learn from the experience of the 2009 pandemic. And then you'll see it goes on to say key elements being effective communications, robust science-based decision-making, and a flexible public health response system able to respond rapidly to a crisis. With the familiarity you have, notwithstanding it might be a few years old, you recall those things to be the real key take-home messages from this review, don't you?
Yes.
And if we can just zoom out from there, please. And if we go to the right-hand column about 2/3 of the way down, see the paragraph starting multi-stakeholder advisory mechanisms. If we can highlight that and expand it. See the second sentence there. For the future, well-structured expert advice should be developed from well-functioning advisory committees in preference to establishing new or separate pandemic advisory structures. I just want to ask you about that statement, and perhaps in the context of the committees that exist at a national level that you are part of. Do you understand that the AHPPC, for example, was in existence prior to 2009?
Yes.
And the other committee with which you've just spoken when you were the Deputy Chief Health Officer of Communicable Diseases that you had a role on, was that something that was in existence prior to 2009?
Yes, it was.
Yes. Can you just describe to us briefly what the AHPPC is? First of all, what does it stand for? Because I'll try, but I'll no doubt stumble over it incorrectly. I'll leave it to the expert.
The Australian Health Protection Principal Committee. So it's a committee comprising jurisdictional representatives as chief health officers or with their equivalent title, directors of public health or chief preventive health officer, chaired by the chief medical officer of the Commonwealth, and with expert representation across various other relevant skills and competencies with respect to public health.
And what's its purpose?
Its purpose is really to consider issues of public health of national significance and of importance for coordinated and evidence-based response. So it will, a little bit like the Health Protection Branch representing broad health protection issues at a Victorian level, it considers similar issues at a national level. So they will be around issues of foodborne outbreaks, issues of communicable disease transmission and outbreaks, but also issues of environmental health significance.
Yes. Can I ask that that document go to page marked 38? I say marked because we have Roman numerals and then ordinary numerals. And if we can just zoom in at least on the left-hand column. You see, Professor, there, I don't know if you can see it on your screen, it looks like you're looking across a room, but at least under 5.2.4, it speaks of isolation and quarantine.
I can see the title.
Let me take you more specifically to a portion of it. We see about 3/5 of the way down that left-hand column, a paragraph that begins a separate system. Perhaps if that can be highlighted and brought up, just the first 5 or 6 lines of that. Separate system of support was provided for contacts identified at the border, as planning had identified that there may have been a requirement for contact tracing, and this is the part I'm most interested in, Professor, and quarantining of large numbers of people after arrival in Australia. Now, first of all, quarantining of large numbers of people after arrival in Australia did not arise in the context of the H1N1 pandemic, did it?
Not in a formal sense, in the sense that some individuals who are identified as close contacts of known cases would have been told to quarantine for a time. But I wasn't part of the pandemic response in 2009. I was working in East Timor during that time.
Mm. And if we can just now move to page 40 of this same document. As that's happening, Professor, you would agree that this was a significant review in respect of looking at Australia's health sector response to pandemics, both not only what we did in relation to H1N1, but perhaps what we ought to be looking at doing in the future should we face a similar scenario?
Yes, I think so.
Yes. We see here, perhaps it's a bit small on your page as it is on mine, but 5.3.4 quarantine is discussed more specifically. And at about 0.4 of the page, just under halfway, there's a paragraph that begins policy and operational plans. And I'll ask that, yes, that be brought up. Now, as at the time of H1N1, this review found that policy and operational plans for managing people in quarantine had not been finalised, either at a state or national level, when the pandemic emerged. You see that there?
Yes.
Accommodation for non-residents identified at the border and requested to quarantine was an issue, as many hotels refused to provide accommodation to individuals. And then it goes on, the roles and responsibilities of all governments for both the management of people in quarantine, both at home and in other accommodation during a pandemic, should be clarified. Now, this was identifying, was it not, that there were issues insofar as quarantine was implemented in respect of H1N1?
Yes.
And specifically, the need for the clarification of roles in any future quarantine situations. It goes on,
correct.
A set of nationally consistent principles could form the basis of jurisdictions to develop operating guidelines, including plans for accommodating potentially infected people in future pandemics and better systems to support people in quarantine. Goes on as the view of some stakeholders that quarantine of contact should only be undertaken for severe pandemics. Now, first of all, are you aware of any further work that was undertaken either at national or state level to implement what this report is identifying by way of the need for clarification and or the development of a set of nationally consistent principles?
No, I'm not aware of any work that occurred nationally or in any jurisdiction of Australia with respect to that.
Yes, and if we can just go finally to the next page of the document. You see at the top of the page on the left-hand side, the discussion around quarantine actually distills specifically into a specific recommendation. If we can highlight recommendation 13, which appears at the top left-hand part of the page. Review the policy on quarantine and isolation, including management support systems and communication. That's plainly a recommendation that fell out of this report, and is it your evidence that you're not aware of any work that was done to implement that recommendation?
That's correct.
You would agree, well, first of all, the board has heard, thank you, that document can come down, and I tender the document, Madam Chair.
Exhibit 156.
The board pleases. The board has heard, Professor, a number of people give evidence about the difficulty in standing up this hotel quarantine program in a very abbreviated period of time, and it's been described as effectively setting it up from scratch. Do you understand that evidence has been given?
I do.
Where in 2011 the recommendation had been made to review the policy on quarantine and isolation, including management support systems and communication, you would agree that that would have been very useful in the circumstances where hotel quarantine needed to be stood up in such a short period of time, had that work been undertaken in the 9 years between that report and hotel quarantine becoming an issue?
I think so. One of the issues in both the Australian Health Management Plan for pandemic influenza and the Victorian plan reflecting it is that there probably wasn't sufficient consideration of coronavirus as a virus of pandemic potential, nor was there such explicit consideration of a program of quarantine essentially for the purpose of keeping a jurisdiction entirely free of the virus. For pandemic influenza, I think there has always been an assumption that it reaches every country, every corner of the world, and that quarantine serves the purpose of minimising the peak of that pandemic and the pressures on the health system by reducing the total number of people who are infected and the waves of transmission. I think the issue with coronavirus is that after the experience of Wuhan and with a reflection that the pandemic is of the greatest severity we've seen for 100 years, probably since Spanish flu, that the impetus for a quarantine program that effectively kept it entirely out of the community to the fullest extent possible was a genuine objective. And so I think in the planning and recommendations around quarantine in this document and in the AMPI and the VIMPI, there was much more consideration about trying to minimise transmission of influenza and not so much a consideration of a almost watertight, if you like, system of quarantine set up previously. But I absolutely take your point that consideration of this recommendation and a pre-existing ready to stand up program would have been of great assistance compared to setting up a program de novo.
Certainly avoids the need to set it up from scratch, as some have described it.
Correct.
And some of the problems that sit around who is in control of setting it up.
Yes.
And indeed how it would be set up.
Yes.
And how it might be resourced to operate.
Yeah, I think all of those issues that would go to planning and preparation and pre-agreed governance and organisational structure are things that could be laid out.
Because these things, that is emergencies, by definition, happen very quickly, don't they?
Yes, they do. I think we were given some notice with COVID-19 because we saw it unfold over a period of time in China before it became an issue in Australia. But nonetheless, things change extremely rapidly once there's importation into a country.
On the question of notice, I just want to come to notice about the prospect of a hotel quarantine program or a quarantine in a designated facility. Perhaps we can bring up Professor Sutton's statement. It's DHS.9999.0002.001. And if we can move to page 31 of that statement, please, Mr. Operator. And if we can highlight paragraph 176. Professor, I just want to ask you about this part of your evidence. You say here, prior to National Cabinet's announcement on the 26th of March, the AHPPC did not endorse the idea of quarantining travellers at hotels or other designated facilities. Now, this answer is given specifically to the question, during March or April, did the committee, being the AHPPC, agree or resolve that it was advisable to require all travellers arriving in Australia to undertake 14 days isolation at designated facilities? Do we read this paragraph, Professor, to mean that the AHPPC was not in agreement of the idea of a hotel quarantine program?
No, I think it's fair to say that the specific question in terms of a recommendation to National Cabinet didn't come up.
So you say that the reading of 176 that we should take from that is it wasn't even being discussed, the idea of a quarantining of return travellers in a designated facility prior to the 26th of March.
No, that there wasn't a formal piece of work as a recommendation to National Cabinet that came before HPPC.
Okay, so is that we seizing upon the word endorsed there? Did the AHPPC, as far as you're aware, have a view about the desirability of quarantining people in hotels prior to the announcement of National Cabinet?
These are matters of Cabinet in confidence for National Cabinet as a body reporting into National Cabinet, so I'm not sure I can speak further on the specific deliberations.
Okay, but suffice to say, you say that prior to the 26th of March, there was no formal endorsement of that as an idea.
Correct.
Can I perhaps take you to a different document, Professor? And it's a document that you yourself have referred to in your statement. It's document HQI.001.002.001. Now, this is a transcript of a press conference given by the Prime Minister on the 27th of March, along with the Commonwealth's Chief Medical Officer, Dr. Brendan Murphy. As I said, this is a document that you have referred to, or at least the press conference is an event that you've referred to in your statement. I want to take you to some certain aspects of it, if I may. Perhaps if we go to the second page and the bottom paragraph. Now, Professor, you appreciate that this is the press conference that the Prime Minister gave, whereby he announced what's now colloquially been referred to as the hotel quarantine program.
Yes.
You'll see that the Prime Minister says there, today we have decided to take further actions targeting what is our greatest area of concern. Dr. Murphy will speak more to that. What we're announcing today enables us to deal with the increasing pressure we have from Australians coming home. You'll see later on in that paragraph, 2/3 of the cases that we currently have are from an Australian who has come home. 2/3. That's very different from what we're seeing in other parts of the world. Our biggest issue, the biggest number of cases, relates to this. Did you, first of all, were you aware that the Prime Minister was going to announce the hotel quarantine program prior to him actually making the announcement?
No, I wasn't.
Perhaps if we move to page 3.
It's fair to say until National Cabinet has decided an issue, it's not fait accompli. So I guess no one should expect in advance of National Cabinet deliberations what an outcome might be.
So if we can move to page 3, the second paragraph there. Sorry, the third paragraph, my apologies. This is the part of the press conference where the Prime Minister announces the hotel quarantine program, isn't it? By no later than midnight tomorrow, that is 11:59 Saturday, states and territories will be quarantining all arrivals through airports, in hotels and other accommodation facilities for 2 weeks. That's the effect of that paragraph, isn't it? That the Prime Minister
Correct.
was there by there announcing the hotel quarantine program.
Correct.
And then finally, if we might move to page 12, please, Mr. Operator. The part that begins Prime Minister, if we can highlight that. Prime Minister told the people of Australia that the decisions that I communicate from this podium, I'll just pause there, That includes the decision to have a hotel quarantine program. Do you agree with that?
Yes.
It says those decisions are the decisions of all premiers, chief ministers and myself. This is not some personal view of mine. These are the decisions of the National Cabinet based on the medical expert advice that we have received in terms of the restrictions that are necessary to deal with the management of the outbreak of the virus in Australia. Now, just going back to that paragraph in your statement, paragraph 176, as at that time, at least as far as you were concerned, the AHPPC had not formally endorsed the idea of quarantining travellers at hotels, I apologise, or other designated facilities, had they?
Not with respect to a formal recommendation to National Cabinet, no. There were discussions about quarantine.
Did that cause you some concern when you became aware that the Prime Minister said that the decisions of the National Cabinet were based on the medical advice that we received?
No, I take it on face value that that's true.
It's not. I'll withdraw that. Let's move back to your statement, if we may, Professor. That's DHS. First of all, I tender that document, Madam Chair.
This is a transcript of the media conference.
It is dated the 27th of March.
Exhibit 157.
As the board pleases. Now, we've already gone to 176, Professor. Perhaps if we go to paragraph 177. Now, you've clarified for us that prior to that announcement, there was no formal endorsement or recommendation by the AHPPC in support of a hotel quarantine program. If we can go to 177, you say the following. Following National Cabinet's announcement of these requirements, the committee met to consider a national response to COVID-19, but did not agree or resolve to advise returning travellers to undertake a 14-day quarantine at a designated, says faculty, I assume that's meant to read the
Facility.
Yes. So not only was there no recommendation or advice given by the AHPPC prior to the announcement, here you say you've met following the announcement and there's still no agreement or resolution to advise to that effect. Do you agree with that?
Yes.
Yes, that document can come down. Thank you. Professor, we've talked about the AHPPC. I want to talk about your view. You're the Chief Health Officer of Victoria. Do I understand that your view, as at 27 March, was that only high-risk cases were to be quarantined in a facility?
No, that's not accurate.
What was your view?
Well, I supported the idea that all returning travellers should be quarantined in a hotel quarantine facility.
That was your personal view, was it?
Yes.
Okay. And did you advise the Deputy Chief Health Officer of that view?
We discussed it. We were in agreement that although it was a significant constraint on individual liberties and individual rights, that it was both necessary and proportionate to do so. But we recognise that many of the Victorian Charter of Human Rights and Responsibilities issues were engaged in coming to that decision. It wasn't taken lightly by any means, but it was balanced against a recognition that already countries like Italy were going through thousands of cases and were facing a catastrophic epidemic that was, ultimately killed tens of thousands of people in that country, and is approaching 1 million deaths globally. And so I think we considered all of those issues at play in coming to a determination that should be written into a public health direction. The Deputy Chief Health Officer had to be satisfied in signing that, but I was absolutely in support of it.
Professor, do you recall sending 2 emails to the Secretary of the Department of Health and Human Services, the first at about 11:15 on the evening of the 26th of March, and the second the following morning at 7:30 in the morning, that is the 27th of March?
If you could refer me to the documents, I might be reminded.
I will refer you to the documents, but given your answer to a previous question, there might be some sensitivity around it. So perhaps, and noting the time, I can see you've got a folder there, and I hope that you have these documents with you, but they're dhs.0001.0040. It's an email from yourself to Ms. Peake on the 26th of March at 10:47 p.m. The next document is the same document number, except it ends in 0004. And the document that I specifically want you to have a look at is a document that ends in 0005, and it's a Word document that has a number of edits to it. That might refresh your memory.
Yes, I recall that.
Yes. And that's a document, the substance of which dealt with the idea of enforced quarantine of returned travellers, wasn't it?
Yes.
And the edits that you had made to that document were to the effect that for international travellers arriving in Australia, only high risk.
Madam Chair, could I just ask that the question, recognise that there's nothing in the document that establishes the identity of the person making edits?
Did you make the edits, Professor?
I don't recall. I don't know.
Well, let me go back to the first document. The first email says, "Hi Kim, not sure if Brendan will accept this, but have agreed to edit his version and see where we land. Are you okay with this?" So you're foreshadowing that you're going to make some edits. And then
yes,
we have a document that appears to have been edited at about 11:20 p.m. on the night of the 26th, and it has edits. Am I correct in assuming that those edits are edits that you have made?
Ms. Harris has an objection, Mr. Rao.
It is being suggested that the document makes apparent on the face of it that both the identity of persons making edits and the timing of them. That's not the case, Madam Chair, from the document that I have. It is the case that there is a cover email, but it's far from clear, and we haven't been provided with a history that would suggest whether there are any pre-existing edits or anything of that nature. If it can just be made clear on the face of the question, given the difficulty with looking at the document itself. Very
easy to do. Professor, did you make the edits?
I don't recall making the edits, no.
Okay. So what we have is an email at 22:47 hours on the 26th of March that says, "I have agreed to edit this version and see where we land." Then we have an email dated the 27th of March 2020, which has an attachment, which is saved by reference to time, 11:20 p.m. And that document has edits within it. Are you saying that you can't recall whether you edited that document, as you said to Ms. Peake that you would?
That's correct. There were multiple individuals editing a document, including Professor Murphy, Ms. Peake, and myself.
Yes, okay. Well, in any event, the outcome of the document that's attached to the latest of those emails provides that in addition to the existing enforced quarantine arrangements. Now, first of all, as at the evening of the 26th of March and the morning of the 27th, enforced quarantine arrangements were enforced quarantine in the home for return travellers, was it not?
Correct.
Goes on, for international travellers arriving in Australia, it is recommended that in high-risk cases, monitored placement in a facility such as a hotel is enforced for those who would normally reside with others at home. Now, what I want to ask you is, as of the morning of the 27th of March, was that reflective of your preferred position in respect of quarantining of passengers?
No, it wasn't.
Okay. Yes, thank you. As of the morning of the 27th of March, what was your preferred position in respect of the quarantining of return passengers?
I was supportive of the National Cabinet's determination that all returning travellers should be in hotel quarantine.
Yes. Thank you, Professor. I want to go on to, once that decision was made, and perhaps now is a convenient time for a mid-morning break.
Yes, we'll take a 15-minute break, Professor Sutton. It's just right on 11:30, so if you could be ready to return at 11, 11:45. Thank you.
Sure, thank you.